Hello, everyone. Hope you are doing well. Welcome back to class. This is part one of week number 5. And in week number 5 here, we are taking a look at some epidemiologic designs and discussing potentially how you can utilize epidemiologic research in your study project. So in this particular lecture, we're going to be looking at measuring health and disease. And so we're going to be exploring the concepts of prevalence and incidence. Prevalence and incidence are sometimes utilized interchangeably, but that is incorrect. And hopefully, the big thing that you take away from today is that these are two different concepts or two different ways to measure the frequency of disease or injury in a population. So, the World Health Organization in 1948 defined health as a state of complete physical, mental, and social well being, and not merely the absence of disease. So, when somebody does an epidemiologic study, researchers will need to define what health is, what that state is that they are exploring or working with, and disease. What is the disease of interest? One thing to point out real quick, like here, this slide or all the slides list Rocky Mountain University of Health Professions. I tried to figure out a way to take that off of there. It's not easy to do so. Long story short, I think I mentioned it before. I teach an epidemiologic class as part of a PhD program at a different institution. I do that once a year. It's at Rocky Mountain University. And so part of this lecture is a component of that class that I teach. So some definitions in epidemiologic studies can be simple. For example, the presence of disease or the absence of disease. Other times they can be a little bit more complex. And I don't think I've got a particular slide illustrating any complexity, but I could take an example from the musculoskeletal world. A disease in one particular study that I'm thinking of, or I should say an injury, was in a professional football team, and the injury of interest was any injury that resulted in 3 weeks or more on the disabled list. So then, any injury that an athlete sustained that did not meet that criteria was not considered an injury for statistical purposes. So it's always important to appreciate what the researchers are discussing. Are they looking at something very simple in nature, the presence or the absence? Or are they, again, not making it complex, but looking at a disease or injury within a certain set of parameters? Now, several measures of disease frequency are based on the concepts of prevalence and incidence. And like I mentioned before, those are two separate things. These things, though, help to answer questions like this: what proportion of a group of people has a condition? Or at what rate do new cases arise in a defined population as time passes? And we will clarify in a bit which one of these is prevalence and which one of these is incidence. And you may know the answer already. Again, it's always important to know who your population at risk is. So those are the individuals who are susceptible to the disease or injury. For example, if I did a study looking at injuries in high school athletes, I would only want to include high school athletes and not collegiate level athletes in my study. Other examples of why you wouldn't want to mix apples and oranges. You wouldn't want to include female subjects in a study involving the prostate. You most likely wouldn't want to include non-runners in a study looking at risk factors for running-related injuries. And you wouldn't include male subjects in a study looking at cervical cancer. The two major classifications for disease frequency are prevalence and incidence. Prevalence, also known as cross-sectional studies, that is the fraction or the proportion or the percentage of a group of people possessing a clinical condition or outcome at a given point in time. There are two prevalence that we'll discuss: a point prevalence measured at a single point in time for each person, and a period prevalence. Period prevalence is almost kind of a mix between point prevalence and incidence. Period prevalence is all the cases that were present at any time during a specific period of time. Now, an incidence study, also known as a cohort study, is a fraction or proportion of a group of people initially free from the outcome of interest, so initially free from having that disease or injury, that then goes on to develop the condition over a period of time. And there's a couple that we'll look at: the cumulative incidence and the incidence density. Again, these are measures of frequency. They are expressed as proportions. So the number of events or cases divided by the population. Prevalence and incidence data become useful to clinicians and researchers when it's converted to rates. So the number of cases and the corresponding number of people at risk. So it's interesting to know what rate, say 10 people per 1,000 develop this disease. And that's really some useful information for you to potentially report in your papers. If you're looking at a psychological condition, you might want to note that psychological condition X is experienced in 10 out of every 100,000 people, or 50 out of every 1,000 adult males over the age of 60 have coronary heart disease Y. It provides some perspective as to the impact upon society. Again, point prevalence is a measure at a single point in time for each person. Here's a point prevalence example. In 2014, there were 200 residents located in a skilled nursing facility, a skilled nursing home. What is the point prevalence of the residents who were impaired by a stroke in June of 2014? So if we use table 1 here, we see that there are 10 people represented. We can assume that the other 190 residents are free from disease. These 10 people here have had a stroke, and it highlights when they were first diagnosed. We see a line that illustrates if they have an impairment. We see a C representing being cured with treatment. Now, is there a cure for stroke? I'm not trying to suggest that there is, but for the purposes of our example, let's go with it. And then X represents if an individual has passed away. So, take a second. What is the point prevalence? Pause the recording if you need to calculate what's the point prevalence of residents impaired by stroke in June of 2014. I'll give 5 seconds of dead air before I continue on. All right, let's continue on here. Did you get this? So if we go to 2014, go down the list, we're looking at the point prevalence of those impaired by stroke. We see 1, 2, 3, 4, 5, 6, 7. So we have 7 people. We have to then decrease our overall number because of 2 that have passed away. So 7 divided by 198 gives us a number, and then we can make it per 100 residents. So 3.54 per 100 residents are impaired by stroke. That would be the point prevalence data. So let's talk about period prevalence. And period prevalence may be of interest in some cases. It's something I don't see in physical therapy, but maybe has more applications within medicine. And that's the proportion of a population that has a condition at some given period of time. And this includes individuals who have the condition at the start of the period and those who acquire it during that period. We'll see a difference here in just a bit when it comes to incidence studies, where incidence, everybody at the start of the study does not have the condition. So what period prevalence does, it is accounting for everyone in that period of time. If you did a point prevalence study, you may only capture a certain number of people. But if you do a period prevalence study, you're going to identify all those people who have the pre-existing condition and the new cases that occur. So in this case, this example of a 1-year period of time, when you start the study, there were 20 people with pre-existing cases of meningitis, and then 15 new cases developed over the 1-year time period. So that then gives you a proportion of 35 cases out of 30,000 in the population. In other words, 11.67 cases per 10,000 people. There's something that is called a lifetime prevalence, and I'm sure there are other types of prevalence designations that are out there. Lifetime prevalence, the total number of persons known to have had the disease for at least some part of their lives. Something that we see in physical therapy a lot is a statistic that's thrown about. The lifetime prevalence of low back pain is like 80%, meaning at some point in somebody's life, they're going to, 80% of the people will experience some episode of low back pain. I'm sure there are plenty of examples like that within medicine too. Factors that determine prevalence, the severity of an illness. If many people who develop the disease die within a short time, the prevalence will be decreased. The duration of the illness. So if it lasts a short time, the prevalence is lower than if it lasts a longer period. And the number of new cases. If many people develop the disease, the prevalence is higher than if few people do so. Here's kind of a figure illustrating things that increase prevalence and things that decrease prevalence. And feel free to pause the recording and read through that as desired. So why are prevalence studies needed? Well, prevalence studies are needed because they give us an idea about the need for potential preventative action or the planning of health services. A key thing, though, is prevalence studies are not strong evidence of causality. So if you're writing up your paper for this class and you find that the prevalence of a particular condition is 33%, well, you might be able to say that the condition of interest affects approximately 33% of the population, and you would define what period of time that comes in. That just tells us basically that it affects the population. It does not, these studies do not really help us know why individuals develop that disease. So here is an example of appreciating the prevalence in a population. Again, I like to do things with athletic populations. So here is a study that reported the prevalence of patellar tendinopathy, so jumper's knee, that pain that's experienced in the patellar tendon due to kind of a failed remodeling response to the stresses placed upon it over the course of playing the sport. Now, this study that illustrated a range of prevalence from 30 to 55%, it highlights the problem of jumper's knee. It illustrates that jumper's knee can be a persistent problem for athletes. The study discusses that the diagnosis may not cause time loss from sport, but it may impact performance. And for some people, because it can be a challenging condition to treat, it may cause an athlete to retire prematurely from their sport. In physical therapy a few years ago, we took a look at patellar tendinopathy and patellar tendon abnormality in male collegiate level basketball players. And so we invited out not only the George Fox athletes, but athletes from basketball teams across the region. And what we did is some diagnostic ultrasound as part of the test that we did to look and see what the tendon health was in the population. Now, these were all athletes who were cleared to play basketball at the start of the season. They weren't on any disabled list. And what we found was through the ultrasound testing and by finding out their symptom status that 1 in 3 male collegiate basketball players presented with either at the start of the season the diagnosis of patellar tendinopathy or patellar tendon abnormality as illustrated on diagnostic ultrasound. So, see, it gives us an appreciation for the health of the population, and this data can potentially be used then by the athletic trainers and the medical staff that works with these athletes to potentially think about, okay, what do we need to do to help our athletes out? We looked at some additional things. As I said before, prevalence studies are not good indicators of causality, but you can start to kind of explore things a little bit, and you might find something like this in a prevalence study. Here's a table that we created looking at potential risk factors. Now, again, the causality of the ability to say that there's a causal relationship is much lower than if we did a cohort study that we'll talk about a little bit in this lecture and in part 2. One thing of interest, the only finding that we found that was statistically significant was looking at starter status. We had hypothesized that starters might be at a greater risk for having patellar tendinopathy or patellar tendon abnormality, when in fact we found the exact opposite, that non-starters were at a greater risk, almost a 3.5 to 4 times greater risk than starters. And I guess you could argue that maybe somebody is a non-starter, maybe a potential reason. Now, again, this is a speculation. Maybe a potential reason that they're a non-starter is that they have this pain, that they can't compete at the same level. They can't jump as high because of an unhealthy knee. Again, that's just speculation. Let's talk about incidence. Hopefully you have a good idea on prevalence. That's answering that question. What is the proportion of a population with the disease, typically at one point in time? Incidence now is that fraction or proportion of a group of people initially free of the outcome of interest that develops the condition over a given period of time. So these are the new cases. So everybody at baseline is initially free of the disease or of the injury, and you're going to be following them for a period of time to see about the onset of new cases. So incidence is calculated by new events divided by the number of people being watched. One way of determining incidence is cumulative incidence, and that's the proportion of individuals who become diseased during a specific period of time. So it's the number of new cases divided by the total population of risk. Here's a very simple, basic cumulative incidence example. Population of runners. You want to know what the cumulative incidence is of developing PFPS, that's patellofemoral pain syndrome, or anterior knee pain, in a population of high school runners. So what we see is there are 2 people out of 5. In other words, 40 per 100 runners are at a greater risk. Excuse me, not at a greater risk. 40 per 100 runners is the cumulative incidence. Incidence density now. Incidence density is a more precise measure, and there's a lot of words on the slide. Basically, this is the number of new cases, and we are looking at things in a context of total person time. So now, with this one, we looked at the previous example there where we just had 2 out of 5 people that developed it. So in other words, 40% or 40 out of 100. And that was the cumulative incidence. Now we are taking into context the total time that somebody is at risk. And so what we would then come up with is that there were 2 cases out of 16.5 person years In other words, we would say 12.1 cases per 100 person years of observation. Some different commonly used rates. You might find some of these things in the medical literature that you're looking at. And of course, there's a lot more than just these. Design of a prevalence study, basically cross-sectional. You have a group of people you're looking at, and then you are collecting information at them at one point in time. So you're taking a cross-section, a slice of the population. So it's good for looking at prevalence. You can examine some associations by using a prevalence odds ratio. These are fast studies to do. They're relatively cheap. Dropout's not a problem, right? You've collected all the information right there. You don't have to follow people. You can do serial cross-sectional studies to provide trends. We'll look at an example of that in just a bit. And these studies are the first step in more rigorous studies. They cannot infer causality, though, so they basically have that inability. They're not good at saying what preceded what. And they're not good for rare diseases or those of brief duration. That obviously makes sense. So, cross-sectional example, I think I get a kick out of this one. This is all made up data. If you're a baseball fan, over time how people, especially in the 90s, steroid use became a big thing. So assessing prevalence of steroid use among Major League Baseball players, let's say in 1990, it was 5% of the population. Well, a serial cross-sectional study or a longitudinal or repeated measures would then illustrate changes. And so maybe, again, all made up data, 1995, that increased to 15%, and by 2000, it was 30%. Do you know who Jose Canseco is? I wonder sometimes as I get older if I lose some of some of my examples, pop culture examples, have the same resonance to them. So again, the importance of prevalence studies, they're good for planning health services. They provide valuable information about what to expect in different clinical situations. They're less time consuming, they're inexpensive, but again, only weak evidence for cause and effect. Cohort studies, this is where you assemble a group of people together and then follow them over a period of time. Cohort studies, also known as incidence studies. I've done a lot of work with Division III athletes because I've worked at George Fox for a period of time. So this is my 10th year, and then before that, I was at a different Division III school. What would be examples of incidence studies that you might look at? Well, what's the incidence of cancer in a population? So you have individuals who are cancer-free until the onset of cancer. That would be a challenging study. Why? The time it takes and probably the size of the population you would need to follow. There are other ways epidemiologically we can do this besides the prospective cohort. We'll explore those in the next lecture. Number 2, all individuals may have recently diagnosed disease and then followed forward in time for outcomes. So here's a different example. It doesn't always have to be just looking for the onset of disease. You could have a population of people with the disease. They get treated, and then you follow them forward in time to look for the a percentage of people that have a recurrence or the percentage of people that die. And I'm sure you most likely have heard of the Framingham Heart Studies, multiple generations, thousands of participants over 70 plus years, thousands of journal articles published. This is the creme de la creme of the kind of cohort or incidence studies that have been done. It illustrates the magnitude where you've got to have lots of people, lots of money involved to do something on a really big scale like this. This is the top. So when we talk about the pyramid of hierarchy of evidence and we look at cohort studies, and I think cohort studies are listed as like the level 3 in some of those different pyramids. This type of cohort study is at the top of that. Strengths and weaknesses, you're able to appreciate the exposure sequence. Did the exposure precede the outcome because everybody at baseline was disease-free or did not have the outcome of interest? You can calculate incidence rates, and you're able to study rare exposures. For example, adverse effects of a drug or unusual occupational exposures. Challenges or weaknesses, you may have to follow a large population over a long period of time. These studies are expensive and they can be time consuming. They're not good for rare diseases because let's say you were monitoring a population of 30,000 people for a particular disease, and what if nobody developed the disease? And then loss to follow-up can introduce bias. All right, that is the end of part 1. I hope prevalence and incidence makes sense. Look forward to your questions if you have any.